Good morning, good afternoon, and good evening. Hi, everyone. Welcome to today's literature online course. My name is Julia, and I'm from the medical team. So today, we will mainly talk about the literature published in 2022, and then I will interpret 10 important literature. If you have any questions, please feel free to ask. And our team members then will have to answer your questions. Okay, so let's start today's literature online course. I will introduce from these three parts. The first part is 2022 new publication review. The second part is publication interpretation, and the third part is summary. Let's see the first part. So here's a table of 2022 new publication review. In 2022, we have already connected 33 new publications, including HA130, HA230, HA330, HA380, and DPMAS. And different indications are included in these publications, such as ESRD, carbamazepine poisoning, paracount poisoning, sepsis, COVID-19, severe acute pancreatitis, and acute or chronic liver failure. And also, in this year, through the CREATE project, we have connected 7 manuscripts. And here you can see these 7 manuscripts. And these manuscripts include the HA330 and the DPMAS. And there are total 4 indications included in these manuscripts, including severe burn, acute liver failure, COVID-19, and severe acute pancreatitis. So let's move on to the next part, the publication interpretation. Before we talk about the publication, let's firstly do a Q&A about HA130. So what is the recommended treatment scheme for HA130? Please write down your answer in the chat box. I will give you 1 minute. Try to answer this question. Okay, so let's see the right answer. So the answer is A, B, C, D. For HA130, we recommend the intensive program 4 times per month, and that means 1 time per week. And the maintenance program is recommended 1 to 2 times per month. And the treatment duration is 4 hours compared with HD or HDF. And the treatment regimen should be adjusted according to the patient's conditions. Okay, next question. Could we install the HA130 on the CRRT machines? Yes or no? Please write down your answers in the chat box. Okay, so the right answer is yes. HA130 can be applied in most of blood purification machines, such as HD machine, hemoperfusion machine, HCF machine, and CRRT machine. However, when the HA130 is used for hemodialysis patients, it is usually connected with HD or HDF machines. So let's start the interpretation of the literature. So here you can see the randomized control study about HA130 applied in ESRD from China. So we all know that classical hemodialysis is limited to remove the middle to large molecules and protein-bound molecules due to the limitations of membrane-based principle. While hemoperfusion is based on the principle of absorption, so it can overcome such limitations, and hemoperfusion can mainly remove the middle to large molecules and protein-bound molecules. So this randomized open-label trial controlled and multi-center clinical study included 438 MHD patients from 37 HD centers. And these patients are divided into 4 groups: low flux HD, high flux HD, HP plus low flux HD, and HP plus high flux HD. And for the groups with hemoperfusion therapy, the patients received once weekly hemoperfusion of HA130. And after the treatment, here you can see the main outcomes. After 12 months, the HP plus low flux HD and HP plus high flux HD significantly reduced the level of blood to microglobulin and PTH, and also reduced the plateaus compared with the low flux HD and high flux HD. Therefore, this study concluded that the long-term HP plus HD can reduce blood to microglobulin and PTH level and also improve plateaus in MHD patients. And this kind of insights is independently on the use of high or low flux dialyzers, showing that the results are linked to the effect of absorption. So based on this randomized control study, how Professor Claudio from Italy comments on this study. So let's see this paper here. So Professor Claudio gave an editorial commentary about this RCT study. And the absorption is a mass separation process by a solid agent, and it differs significantly from the classical mechanisms of convection and diffusion based on the dialysis membrane. Hemoperfusion can overcome such limitations by the dialysis membranes, and it can achieve effective removal of a wider spectrum of solids. And this RCT study about HP plus HD showed that the addition of hemoperfusion once a week compared with low flux HD and high flux HD significantly improved all the target endpoints compared to HD alone. And further analysis demonstrates that positive results depend on the addition of hemoperfusion independently on the membrane flux. This study has important implications and may open interesting treatment opportunities for chronic patients. And furthermore, in different geography areas, high flux HD or HDA may not be available for technical or economic reasons. In the conditions, the addition of hemoperfusion once weekly may represent an interesting solution. So here is an expert consensus about HA130 applied in ESRD from China. This expert consensus recommended the complications and the appropriate patients and the HP treatment frequency, and further complications including severe uremic plateaus, severe uremia-related sleep disorder, and protein energy wasting, and these complications. And for different complications, we recommend the different HP treatment frequency. For example, for the severe uremic plateaus, once or twice every 2 weeks is recommended. And for the severe high beta-2 microglobulinemia, 1 to 3 times a week is recommended. So this consensus concluded that hemoperfusion therapy has proven effective for the maintenance hemodialysis patients, and the combination therapy of HD or HDF with HA130 can prevent maintenance dialysis-related complications and improve quality of life and prognosis. So let's make a summary of HA130. Firstly, in general, we recommend using HA130 once a week and 4 hours each time. And the indication of HA130 is ESRD. We all know that conventional hemodialysis has a limited removal effect in middle to large molecules and protein-bound molecules, where hemoperfusion can effectively remove these toxins in uremic patients. So the nephrologist may have interest in this kind of therapy. The key benefits of HA130 are to reduce PTH and beta-2 microglobulin levels, improve pruritus, and improve quality of life and prognosis. And the biomarkers of HA130 are middle to large molecules and protein-bound uremic toxins. So what's the commercial opportunities of HA130? Firstly, it has a significant clinical effect, and it has a good compatibility and economic efficiency. Besides, it's very easy to use in clinic. So the next part is about HA230. Firstly, let's do a Q&A. So which of the following substances can be absorbed by HA230? Please write down your answer in the chat box. ABC. ABCD. Okay. Anyone else? ABCD. Oh, yeah. Okay, so the right answer is ABCD. All of the substances can be absorbed by HA230, the paracount, carbamazepine, organophosphate, and methotrexate. Okay, so this study is about HA230 applied in severe poisoning from China. This study is aimed to observe the clinical efficacy and safety of FPSA-CVVH applied in the treatment of severe poisoning. 14 hospitalized patients were included in this study, and all the patients received the treatment of FPSA, CVVH, and also received HA230 hemoperfusion therapy. The process of FPSA, CVVH treatment lasted 8 hours, and a sequential therapy of CVVH lasting 16 hours was also performed for 3 consecutive days. And after the treatment, this study observed a significant decline in the levels of clinical monitored poisons or drugs. And 10 patients recovered and left the hospital with normally hepatic and renal functions. So the study concluded that FPSA CVVH may effectively remove the highly protein-bound poisons, improve hepatic and renal functions, and increase the treatment success rate of patients with severe poisoning. So let's make a summary of HA230. Firstly, we recommend the using HA230 3 to 5 cartridges for each patient and 3 to 4 hours each cartridge. And the indication of HA230 is drug overdose and poisoning. But the charcoal hemoperfusion has been widely used in poisoning before, but it has the lower biocompatibility and higher side effects. While HA230 vaccine hemoperfusion has been proved to be effective in poisoning, and it doesn't carry the risks of charcoal hemoperfusion. So the emergency or the ICU doctors may have interest in this kind of therapy. And the clinical studies has shown that HA230 can clear overdose drugs and poisons, stabilize the hemodynamic status, alleviate complications, and shorten hospitalization, and also improve the survival rate. And the biomarkers are poisons and overdose drugs. So what's the commercial opportunities of HA230? So firstly, it's very easy to operate in clinical, and it's safe, and it has significant efficiency for the patients. So the next part is about HA330 and HA380. So firstly, let's do this Q&A. What are the main clinical applications of HA330 or HA380? Everyone, please write down your answer in the chat box. ABD, AC, AB, ABC, ACD, okay. Okay, thank you for your answer. So the right answer is A and C. HA330 or HA318 can be applied in the sepsis or septic shock and trauma and bear. For the liver failure, we don't recommend using HA330 or HA318. We recommend using VP mask. And for the ESRD, we recommend using HA130, not HA330 or HA318. Okay, so next question. Which is correct about the treatment scheme of HA330 or HA318? Please write down your answer. Which is correct about the treatment scheme of HA330 or HA318? AB or ABD? Just the A. Multiple choice. ABD. ABC. Okay, so the correct answer is ABD. So for HA330 or HA318, we recommend using 1 to 2 cartridges per day for 3 consecutive days. And the suggested duration of each cartridge is 6 to 8 hours, no more than 12 hours. So we can choose C. And the doctor could adjust the treatment scheme according to the patient's condition. So, okay, so that starts the interpretation of the literature. So here's a study about HA330 applied in the severe acute pancreatitis. So for the severe acute pancreatitis, a large number of inflammatory mediators will release and will cause the multiple organ dysfunction syndrome. And this study was to investigate the efficacy of PIRRT plus HP in treating severe acute pancreatitis. 105 patients were enrolled in this study and were divided into control group and intervention group. And for the intervention group, the patients received PIRRT plus HP for 3 to 5 cycles, and the CVVH lasted 6 to 8 hours, and hemoperfusion lasted 2 hours. And after the 3 and 7 days treatment, the Apache 2 score decreased significantly in the intervention group than the control group. And also, no deaths or treatment-related serious adverse reactions occurred in both groups. And also, you can see the table here of the results of renal function recovery. We can see that the proportion of AKI patients in the intervention group was much higher than the control group. So this study concluded that PIRRT plus HP therapy could not only improve the general condition, but also reduce the inflammatory cascade of patients with acute pancreatitis. And for the severe acute pancreatitis complicated with AKI, this therapy may accelerate the recovery of renal function. So this study is about HA330 applied in the severe COVID-19. And the severe COVID-19 includes the cytokine release syndrome. And the studies have suggested a prognostic value of IL-6. So among the severe COVID-19, the use of hemoperfusion to remove the inflammatory cytokines is increasingly widespread. And this study included one patient suffering from COVID-19, and this patient received the ECMO because of severe acute respiratory failure, and also received 3 cycles of hemoperfusion with HA318 cartridges and lasted 12 hours each for 3 consecutive days. And after the treatment, IL-6 value dropped down, and at the end of the third treatment, the chest X-ray image was markedly improved. You can see here in the picture. And also the AKI improved too. So after 13 days, the patient was successfully weaned from ECMO and mechanical ventilation. So this study concluded that the use of hemoperfusion reduced the IL-6 levels and improved chest X-ray imaging and AKI. So this study is about HA330 applied in Colchicine pulmonary. For the Colchicine pulmonary patients, they don't have the specific antidote, and the early detection of poisoning is very important because it can lead to multiple organ failure and even cause death. So a 36-year-old married woman was included with Colchicine poisoning was included in this study. And this patient received continuous hemodialysis for 8 hours and hemoperfusion with Jeffron HA313 cartridge for 8 hours. And after the treatment, on the 3rd to 5th days of hospitalization, this patient was alert and able to eat and drink. And the laboratory test results turned to normal. You can see here the table. On the first day, the patient was discharged in stable condition. So based on these outcomes, this study concluded that using extracorporeal removal methods such as hemodialysis and hemoperfusion to remove the drugs from the blood are very rarely used, but it can be effective and save the patient with colchicine from the knee. So here's a study about HA313 applied in acute severe organophosphorus pesticide poisoning. The acute severe organophosphorus pesticide poisoning is a very common critical disease in the emergency room patients, and it will progress rapidly and quickly and leads to the organ failure and will finally cause death. So this study aimed to observe the clinical effect of PHC compared with hemoperfusion in treating acute severe organophosphorus pesticide poisoning. 61 patients were included in this study and were divided into experimental group and the control group. The patients in experimental group received HA313 hemoperfusion therapy for 2 to 2.5 hours and were perfumed 1 or 2 times according to their conditions. And after the treatment, we can see the outcomes in the table. Compared with the control group, the experimental group significantly reduced the awake time, mechanical ventilation time, and the healing time. So this study concluded that the application of PHC compared with hemoperfusion in the treatment of acute severe organophosphorus pesticide poisoning can significantly reduce organ injury and have a curative effect, shorten the course of treatment, and improve the quality of life. So let's make a summary of HA313 and HA318. Firstly, for the regimen, we recommend 1 to 2 cartridges per day for 3 consecutive days and 6 to 8 hours each time. And the indications are sepsis, septic shock, severe acute pancreatitis, severe burn, COVID-19, and other disease related to septic release. And the mechanism involved in the pro-inflammatory state in sepsis or septic shock, severe burn, or COVID-19 or severe acute pancreatitis. So the ICU doctors may have interest in this kind of therapy. And the clinical studies has shown that HA313 and HA318 can improve the general conditions, reduce the inflammatory cascade, reduce L6 levels, accelerate the recovery of renal function, and improve AKI. And the biomarkers are inflammatory cytokines and triglyceride cholesterol. And what's the commercial opportunities of HA330 or HA318? So firstly, it's safe and it's effective for the patients. And also it can refresh the doctor's knowledge of hemoperfusion. So next part is about DPMAS. Firstly, let's do this Q&A. So which indication can DPMAS therapy be applied in? Please write down your answer in the chat box. Which indication can DPMAS therapy be applied in? AC, ABD, or ABD? Okay, so the correct answer is A, B, C. So DPMAS therapy can be applied in liver failure, hepatitis, and jaundice. And for the sepsis or septic shock, we recommend using HA330 or HA380. So here's an expert consensus about DPMAS applied in liver failure from China. So the artificial liver therapy is a type of blood purification, and it can bring benefits for the patients, such as it can remove the harmful substances, supplement essential substances, improve the internal environment, and temporarily replace some functions of the failed liver. And as one of the artificial liver therapy, DPMAS has been recommended in this expert consensus because it has the advantages of rapid removal of bilirubin, inflammatory mediators, and also without requiring the plasma. And the intended populations are patients with liver failure, hyperbilirubinemia, and hepatic encephalopathy, pre-operative treatment of liver transplantation, and multiple organ dysfunction syndrome with jaundice or sepsis. And also, the artificial liver combination models are recommended in this consensus, the DPMAS plus PE and DPMAS plus HDA. DPMAS plus PE is indicated for the patients with liver failure, hyperbilirubinemia, especially for those with total bilirubin levels over 500. And DPMAS plus HDA is indicated for the patients with severe liver disease and patients with severe jet toxicity. All in all, artificial liver is an effective method to treat liver failure. So here's a study about DPMAS applied in acute and chronic liver failure. And this study aimed to compare the therapeutic efficacy and cost effectiveness of comprehensive medical treatment, PE, and DPMAS plus half-dose PE in patients with acute or chronic liver failure. A total of 186 patients with acute or chronic liver failure were enrolled in this study. And these patients are divided into 3 groups: PE group, control group, and DPMAS plus PE group. And after the treatment, we can see the outcomes here. The DPMAS plus PE group significantly improved the 28-day effectiveness and 19-day survival compared with the PE group. And also, DPMAS plus PE group significantly reduced the total bilirubin and the creatinine compared with PE group. And also, the DPMAS plus PE treatment was more cost-effective. So let's make a summary of DPMAS. So the indications of DPMAS are liver failure, hyperbilirubinemia, hepatic encephalopathy, and pre-operative treatment of liver transplantation and MOGS with jaundice or sepsis. So the liver transplantation is the only certain way for liver failure, but it is limited by the lack of donors and high cost. And the PE has been shown very useful in clinical, but it also has some limitations of plasma dependence, unstable dynamics, and the risk of dissemination, disease, and allergic response. where DPMAS therapy was proved to be effective and it can be as the complement therapy. So the hepatology and infectious doctors may have interest in the therapy. The key benefits of DPMAS are to remove the bilirubin and inflammatory mediators, and also DPMAS can improve the survival rate. And the biomarkers of DPMAS are bilirubin dioxide, inflammatory mediators. And so what's the commercial opportunities of DPMAS? The first, DPMAS has a safety and also it has the cost effectiveness, and it can enrich the therapeutic strategy. So lastly, let's make a summary. For the critical disease, we recommend using HA330 or HA318 because they can lower the mortality rate, reduce mechanical ventilation, lower sofa skull, and improve renal injury. And for the ESRD patients, we recommend using HA130 because it can reduce macro-inflammation, improve quality of life, improve nutrition, reduce complications, stabilize hemodynamics. And for the liver failure, we recommend using DPMAS because it can reduce bilirubin, lower the mortality rate, reduce the incidence of adverse effects. And for the drug overdose and poisoning, we recommend using HA230 because it can reduce the poison concentration and improve the survival. So all of our products have been proven safe and without obvious side effects in clinical. And also they are very easy to perform no matter in single mode or when compared with ECMO, CRRT, or HD, or HDF. And also, our products could be performed in children and adults. The new clinical indications and large-scale studies are becoming more and more available. So here I would like to recommend this website for you because it will be very convenient for you to search the literature of diaphragm. So you can scan the QR code here, and then you can enter into this website, the medical center website of diaphragm, and you can click the literature, and then you can write down the keywords in this box to search the literature And also, we have collected some labels for you to search the articles. For example, the deployment, model, targeted substances. So we believe that this website will be very convenient for you to search the literature of diaphragm. So that's all. Thank you for your patience and thank you for your listening. So if you have any questions, please feel free to ask. You can write down your question in the chat box if you have any questions. Or you can scan the QR code here. You can scan the QR code here to write down your answer and leave your email so that we could contact you. And if you want the slides, you can scan the QR code and leave your email, and we will send today's slide to you if you want. Thank you. So no question. Okay, here we have one question. Does deep mass remove ammonia? Sam, please have to answer this question. Thank you.
Hello, Julia. Thank you for the great presentation. For the ammonia, here I'm going to have some comments because ammonia is water-soluble toxins. So water-soluble toxins should be absorbed by the dialysis membrane mainly, but in some of the DPMAS literatures or DPMAS papers, we find that the DPMAS will improve the renal function, and therefore maybe the liver will have like a good outcomes, and the ammonia maybe will improve indirectly by the improving of other liver function. So suppose there is no direct absorption, but after the liver is improved, then the ammonia will improve. But if the ammonia levels is very high, then we should to have the measurements for that, for example, dialysis or any other methods. Okay, thank you.
Okay, thank you, Sam. Okay, here comes another question. What about the removal rate? Sam, please.
For ticagrelor, for triglyceride and cholesterol, the removal rate. The removal rate is very difficult to be estimated because the concentration from patient to patient is different, and also the patient's condition himself. So usually the higher concentration is the higher absorption, and there is many cases from the clinical after the absorption of triglyceride and cholesterol. We find that there's a significant declines declines for the triglyceride and cholesterol absorption. I remember one case in the beginning, it was about 4,000 milligram per deciliter. After 3 sessions, it's decreased to 300 something. So there's a big decline of triglyceride and cholesterol levels after, especially the triglyceride levels after the treatment. And when you see the cartridge after the absorption of these lipids, it will become becomes like a milk color or milky color. That means there is a lot of lipids inside the cartridge after the absorption of these triglyceride and cholesterol, and this mainly happen in patients with hyperlipidemia-induced pancreatitis, and also in some other genetics conditions.
Okay, thank you, Sam. Any other question? Or like if you want today's slides, you can scan the QR code and leave your email so that we can contact you and send today's slides to you. If there's no other questions, let's finish today's course.
Okay, see one raising hand.
Okay.
Hello, Abul Fazl. You can, you can open your mic.
Hello, Julia, and hi, guys.
Hi.
I'm from Nismo from my come from is Iran. I have a question. What different between HA 30 130 and 380 in critical disease?
Yeah, you know the major differences is, you know, that the HA380 contains 380 milli of resins compared to 330 milli of resins in 330. So the absorption surface area of HA380 is more higher. In 380, the absorption surface area could reach 60,000 square meter, but in 330 could reach 50,000 square meters. So bigger absorption surface area in 380. Also, there's another some differences, and you can leave your email to send some other differences. You can scan the QR code, and we will send you more explanation about that.
Okay.
So if there is no any other question, Julia, I think you can end the session.
Okay, so since there's no other questions, let's finish today's course. And thank you again for your participation in today's course. And if you have any question, any other questions, please scan the QR code. One more minute, and then we will finish today's course. Thank you for your listening, and thank you for your patience. Have a nice day. Bye bye, guys. Have a nice day. Bye bye. Okay, bye bye, guys.